Wondering if thousands of miles away, the sky's just as blue. It's as if I'm stuck in yesterday.
Basics should be always first. Ablation is widely accepted as one of the curative treatments for early HCC. Many novel assistant techniques will enhance the therapeutic outcomes and safety. However, more important factor for successful ablation depends on how much the basics of ablation procedure is performed. The basics are well known to us, but I'm afraid if we often forget them. The basics include careful selection, precise planning, accurate placement of applicator to the index tumor, optimal ablation, learn from each case. Careful selection of the best candidate for ablation is the first step to successful ablation. Stratification of feasibility may be beneficial for the careful selection. Precise planning is almost half of successful ablation. Please specifically decide all the details. Accurate placement is the most critical part for successful ablation. If we consider single ablation, we should carefully insert along the long central axis through the index tumor. If we consider to use multiple electrodes, punctual placement of each electrode is very important to provide ideal pedicle ablation zone with ablative margin. Don't forget, HCC will recur until the end of patient's life. Optimal ablation may be better than just extreme ablation in our patient with poor hepatic reserve. To balance between complete and safe ablation is very important. Final of the basics is to learn at least one thing from our daily case. Learning by precise review of post-ablation imaging with all ablation procedures seems to be untold or forgotten tips for improving one's skill for better procedure. Please start from the ground when you want to build a gorgeous building. Novel is meaningless without basic. Thank you. Careful selection of the best candidate is the first door to successful ablation. Many guidelines of HCC treatment propose general guidelines only according to tumor size, number, and location, including perivascular or subcapsular. However, besides tumor size, number, and location, many more factors should be considered for the best selection. So, when you select a patient for ablation, please see the forest first and then move to your tree. Those factors include patient's age, general condition, hepatic reserve, naive versus recurrence, previous treatment history, coagulopathy, and tumor markers. And tumor size and configuration, tumor conspicuity and guiding modality, heat sink effect, collateral thermal damage, any potential technical difficulty, and so on. So, given the many factors on feasibility assessment, the feasibility usually shows a broad spectrum like this, from the best candidate to absolute contraindication. Therefore, we need tailor-made selection strategy depending on the feasibility. Unfortunately, there is no standard objective system for feasibility assessment, which has been proven in the treatment guideline. If we have that kind of system for feasibility assessment, it will be very useful for communication with our referral physicians or patients. About 10 years ago, actually, I proposed a preliminary feasibility assessment system using 5 important factors, including electrode path, dangerous organ for thermal injury, tumor size, tumor conspicuity, and the potential heat sink effect. During the planning ultrasound, I graded into 3 categories in each item and assigned the score from 1 to 3, depending on the technical difficulty. I called the list of score in each category as POSH score, and some of each score was considered as POSH class, just similar to child score, which means overall technical feasibility. So the feasibility can be categorized according to POSH score and class like this. But I think this push system is still preliminary with many limitations. I hope to see more sophisticated system for more objective assessment of feasibility near the future. The best candidate for liver ablation has been widely accepted as a single smaller than 3 cm conspicuous tumor with well-defined margin, non-perivascular, non-subcapsular, non-perihilar location. If the tumor is beyond the best candidate, we can call potential candidates, which means technically feasible but require more attention to achieve complete and safe ablation. The worst candidate means ablation is not recommended due to high risk of incomplete ablation or major complication. Alternative treatment should be considered first for those patients. Please wisely select a proper weapon depending on the feasibility. But this kind of list of weapons cannot be standardized. You should have your specific plan depending on the situation of your institution or your experience. As we know well, the careful selection is the first step to guarantee the best outcomes of ablation. As Aristotle said, planning is the half to achieve successful ablation. Without well-designed planning, we cannot build this kind of gorgeous building. After you decide to ablate, you need to perform the planning on how to ablate and what you have to consider during your ablation. The planning phase consists of 3 parts. First, patient. Second, tumor. Third, procedure. Regarding the patient, we need to meet the patient and evaluate all the details about the patient. Age, medical morbidity, general condition, comorbility, obesity, previous treatment history, bleeding tendency, tumor markers, etc. Meet your patient as a doctor in the bright outpatient office. Tumor information is the most critical part to make a plan for optimal and safe ablation. Please precisely review all the images and define the index tumor clearly. Measurement of the detailed diameter in 3 dimensions is necessary to decide the detailed ablation parameters, including the device type and powers. Evaluate tumor margin, either well-defined or ill-defined. Checking any peritumoral structures are essential to modify the ablation protocol or use assistant techniques. Safe electrode path should be found during the ablation during the planning ultrasound. Conspicuity on the index tumor is defined for adding assistant technique including fusion or contrast-enhanced ultrasound. Think more about the tumor in 3 dimensions. If so, you may realize there are so many innumerable technical options. Final step is the detailed planning for the procedure. Patient position, anesthesia, energy source, guidance, fusion, contrast-enhanced ultrasound, artificial ascites or effusion. What kind of ultrasound probe? Specific electrode path, specific intercostal space, applicator type, including number and active length, exact placement site, central tumor through, marginal touch or non-touch technique, target ablative margin, potential event or complication. Devils are in the details. Please plan in details as much as you can. Please make a document about all the details of your planning. Perform the procedure according to your plan. And after the ablation, please compare the real procedure with the planning Define the difference and think what was the reason. One more, the real last step of planning is the mind training, so-called rehearsal. Although the planning is most important, successful ablation depends on how much accurately one operator performs the procedure according to the plan. As we all know, the devils are in the details. Accurate placement of electrode is critical to achieve accurate ablation. Any powerful device cannot guarantee successful ablation if we miss the accurate placement of the applicator. Punctual placement of applicator has been underestimated so far, a kind of undervalued stock. As you can see, the plan and the reality usually shows a different story in many of our cases. However, the difference between plan and the real procedure can be minimized by accurate performed procedure. I think it is necessary to consider the tumor three-dimensionally for accurate placement of the electrode. If we plan to ablate with single ablation for smaller tumor, we should insert along the central axis of tumor as much carefully as we can. For accurate placement, please take your time. Slow insertion may be better than just a quick love insertion. For accurate ablation, we don't need to such a nice car, Ferrari. School bus may provide more benefits to accurately place the electrode through or around the index tumor. Please remember there are 3 bus stops ahead along the electrode path. The first stop in front of tumor. The second stop at the central core of electrode of the tumor. Third stop beyond the posterior margin of the tumor. We should stop at each point and check whether the electrode is accurately placed along the central axis of tumor at different planes by rotating the ultrasound probe. If you are sure, move to the next point. Even if the electrode is placed off the central axis after inserting up to the third point, just leave it there and don't try to reposition. Just check the direction of eccentricity, which will be useful to plan repositioning of the electrode after the first ablation. The reinsertion cannot guarantee the accurate insertion along the central core of the tumor, and reinsertion process before ablation can be a risk of tumor seeding along the electrode path. So, stop at 3 bus stops. Don't miss your student. Check where you are at each bus stop and adjust the direction toward the central line of the tumor. Before starting ablation, it is very important to check the tip of each electrode was placed enough posteriorly. When you perform the hepatic ablation, please remember this is not a single battle, because HCC continuously recurs even after curative resection. This is not simply about size or speed. We need to remind that our patient is also fighting for the hepatic reserve due to liver cirrhosis. Again, hepatic reserve is the most important prognostic factor for the patient treated by any treatment modality. Thus, optimal treatment should be always considered when we plan or perform ablation as well, because HCC would frequently recur almost until end of patient life. There are many ways to catch the mouse in this old house, from ablation to transplantation. We all know that the optimal tool is better to cut the different sized fruits. This principle can be applied to HCC treatment. Furthermore, Even if we choose ablation, please stay optimal. I wonder if we really use this luxury car to visit into a neighbor's house. Optimal may be better in most daily procedures. Circumferential ablative margin is the most important strategy to get the best therapeutic outcomes after any kind of local ablation. In most interventional oncology society, 5 to 10 mm ablative margin is widely accepted. Local tumor progression is an inevitable event after any kind of ablation. Although the definite relation between the LTP and overall survival is still not sufficient yet, we need to clarify more through the well-designed comparative studies. We need to try to achieve circumferential optimal ablative margin as much as we can. However, we also should avoid just a simply big enough ablation, considering the hepatic reserve. Please always keep in mind balance between complete and safe ablation. Don't forget the poor liver of our patient suffering from HCC. Many more treatments are surely coming near the future. For optimal ablation, the detailed planning and accurate placement of electrode are essential. Take-home message: please keep optimal. I would say our daily case is the best teacher. Any simple case has at least one teaching point. After each procedure, please take your time to carefully compare pre-ablation planning and post-ablation imaging study. Find any difference between the planning and your real procedure. Specifically define what is the difference between the planning and real procedure. Carefully compare the ablation zone at the time of planning and the real ablation zone after the procedure. You can see the planned ablation zone here. I thought ablation zone might be optimal during the ablation. However, the post-ablation CT tells a different story. As you can see, the ablation zone was a little bit eccentrically formed towards anteriorly. So, posterior ablative margin seems to be not sufficient. After finding the difference, please think over what may be the reason of the difference. Please ask to yourself the following 10 questions. Following 10 questions can be used as a kind of checklist. I like to recommend for you to make notes about 3 items. First, what did you do well according to the planning? Second, what did you do badly in this case? Third, what did you learn from this case? If you repeat in every your case through the year, I'm quite sure your clinical experience will be mature day by day. Again, write down after each your procedure. If there is anything well done, remember and repeat it. If there is anything badly done, don't forget and don't repeat again. If there is any lesson from this case, please share with your colleagues and apply from your next case. Learn from your daily case. Thank you for watching.
Wondering if thousands of miles away the sky's just as blue. It's as if I'm stuck in yesterday when I'm thinking of you. 'Cause when